This is BFR Tuesday. My name is Cara. I am a clinician out of Dallas, Texas at my clinic, The Body Lounge. We do this BFR Tuesday every week, and I talk about kind of whatever I want to talk about regarding BFR, or people ask questions throughout the week, either on social media or send me an email, which everybody here is welcome to, and I chat about them, because if one person has a question about it, then we kind of all have a question about it. So today what we're going to do is talk about proximal, distal, and contralateral effects using BFR on strength and hypertrophy. And this was a randomized controlled trial by Dr. Bowman, published in 2019. So we're trying to be as update and current as possible. So I'm going to share that. I'm going to share that article with you, so that way you have it, and I'll give you a second to download it. And while you're downloading it, I am going to share my screen, open mine up, and just kind of go through some of the highlights. Because the question a couple times this week, what I got was regarding proximal benefits. So what I'm talking about is, if I put a cuff and I put it around my leg here, it's pretty intuitive that everything distal to the cuff placement should improve. I mean, it's not guaranteed, but it's kind of just assumed in our mind that, hey, anything distal to the cuff. But what happens proximal to the cuff also seems to be of a benefit. So if I put the cuff on my upper leg, does my core, that's the question I got this week, is what would I do for core training? Does my core improve? Does the other side improve? So if I put a cuff on this arm and I have surgery on this arm and I can't do anything with this arm, and I still want to try to improve strength, if I just lift with my BFR arm, do I get strength on the opposite side? So like early phase of a rotator cuff, when they're still in a sling and they're still immobilized, should we be training it on both sides? So kind of some cool stuff, and really updated research. So I'm going to share my screen so we can kind of get to it. All right, so here's Dr. Bowman. And as you see, the title of this article is Proximal, Distal, and Contralateral Effects of BFR Training on Lower Extremities. So I'm going to go through what I highlighted just to kind of give you an idea of what he was seeing. So the purpose of the study was to define the clinical efficacy of BFR training on muscle groups, both proximal and distal to tourniquet placement, as well as the contralateral non-BFR extremity. So they first did baseline testing, and they did baseline testing to figure out what is somebody's 1 rep max, so they could be consistent with their training. And what these researchers did is they worked at 30% 1 rep max for 6 weeks, 2 training sessions per week, at least 48 hours apart. So fits pretty nicely with a clinical case. Like in the rehab setting, I typically will prescribe twice a week, and I try to get them like Monday, Thursday, Tuesday, Friday, something to try to get at least 48 hours apart. What I know is that at delayed onset muscular soreness peaks at about 72 hours. If I can get them 3 days apart, then I'm going to be in a pretty good space to be able to make sure that they've had enough recovery prior to their next training episode. They measured limb circumference using a standard tape measure. Thigh measured 10 centimeters proximal to the superior pole of the patella, and the leg measured 10 centimeters distal to the inferior pole of the patella. They worked at 80% arterial occlusion. So that's one of the reasons why individualized limb occlusion pressure has been so popular. Number 1 is to ensure safety and efficacy. Number 2 is consistency between these research papers, so that way we know what we know what we're measuring. Exercises were performed in a series of the following: 30 reps, 30-second rest, set 2, 15 reps, 30-second rest, set 3, 15 reps, 30 seconds. This is our standard rep scheme. The cuffs are inflated throughout the whole session. In the BFR group, so if you were in the control group, the non-BFR group, I should say, they exercised on both legs. In the BFR group, they only put the cuff on one leg. Now, what I love about these studies, and it gets me all, my nerd side just like pops out, because the people are their controls. So if I'm measuring the differences left to right, I'm my own control. So I take out a lot of the confounding factors with other research when we're trying to compare apples to apples. The other thing that I did, what I think was pretty cool, and something that we have to take into consideration as clinicians, is that the goal was to achieve a rate of perceived exertion of 7 to 8 for each exercise, and weight was increased according to accomplish this. Now, think about why this is important for clinicians. Most patients come into me and I don't have the convenience of a 1 rep max on them. So I've got to guess. Have I guessed wrong? Absolutely, I do it a lot. I typically, for the first couple of sessions, undercook somebody before I overcook them, because if I don't, I tend to overestimate what they can do with the cuffs on. More recent research this last couple months has shown that after about 3 sessions, people get more comfortable with the cuffs and their ability to do more work is increased. But for those first 3 sessions, I'm really trying to figure out how much weight can they use, how do they tolerate the pressures. And that's, if you remember, what I call an on-ramp program, 2 weeks of BFR in an on-ramp. Little lower pressures, little lower weight, let them get used to the rep schemes. Why this is important with clinicians is that I typically don't have a 1 rep max, and I'm using either just body weight or resistance bands. And so what I know is that if I don't get them to a 7 or 8 out of 10 for each exercise, no matter what the pressures was, I probably don't have enough weight. So we can add a little bit of load even during their exercise scheme to make sure that they get to the 7 out of 8. We don't want to get higher than an 8 out of 10, but anything lower than 8 out of 10 probably isn't enough pressure to create that hypoxic environment that we're looking for. Average age was 27. I should say mean age 27. What they did is they looked at percentage change and group comparisons between BFR and non-BFR limb, BFR and control group, and non-BFR limb and control group. And that was found in tables 2 through 4. And then they did a comparison of the BFR limb with the control group, demonstrated a significant greater increase in thigh and leg girth. So when we look at table 2 here, here's our control group, which is the non-BFR. And then what they did is they compared this to the BFR limb. So look at the difference between the BFR limb and the control. Pretty crazy difference, 0.8 to 3.5 change. Lower leg, significantly different. Strength, power, torque, knee flexion, peak torque, power, hip adduction, hip extension, plantar flexion. All greatly and vastly different with BFR versus non-BFR. And then I don't know if I pointed out what exercises were done. Straight leg raise, hip flexion, side lying hip abduction, long arc quadricep extension, standing hamstring curl. So standing hamstring curl, it's pretty cool that they use that. Something easy for us to do, usually doesn't include any weight unless we are using an ankle weight. All right, so then we get into the discussion. You can look at these tables, but really you're looking at comparing BFR limb to non-BFR limb. But even the bigger story is the non-BFR limb here to here. Like you're seeing really 0.8 and 0.4 in circumference in the control group, meaning there's no BFR on there. And here's the non-BFR, non-exercising limb, 2.3 and 1.2 change. So we're getting a crossover effect, at least it appears. You can go through the rest of these numbers. I don't have to look at them. You can also look at these p-values. Some of these p-values, not so great, but you look at some of these other p-values and they're strong. Okay, so from conclusion, the authors came up with Substantially greater increases in strength, both proximal and distal to the cuff. Contralateral extremity may also benefit from a systemic or crossover effect. So when we are talking about this systemic effect or this crossover effect, I think that's where it applies to the spine. So a study came out, I think it was last month. I need to pull it again because now it's kind of crystal clear about how important that study was when it comes to BFR and training for core. And what they did is they looked at McGill's Big Three, which is a side plank, curl up, and a bird dog. And they compared those outcomes for lower back pain patients with just generalized exercise. And what they found was that generalized exercise was just as effective as being these specific, what he calls the Big Three exercises. And so that plays into using BFR and saying that, hey, we can do whatever exercises we want as long as we're doing it at high enough intensity, and BFR allows us to do that. So for example, most of my patients for their lower backs or even their necks, we could do BFR cuffs around the legs, glute bridges, leg raises if possible. That might be aggravating for their lower back. Side lying work, clamshells, abduction, even just straight walking with the cuffs on, trying to drive growth hormone, drive insulin growth factor, and then take the cuffs off, and then having them do bird dogs and side planks, and maybe do the Big Three there. So I think just exposing them to the cuffs drives physiological adaptation, and then you can just kind of apply whatever exercises you like, knowing that there's really not a lot of stress, because if generalized exercise is just as good as individual exercises, all we have to do is make sure that we don't exceed the capacity of the tissue at that time. What I mean by that is that we don't put so much pressure into the disc or the joint that it aggravates people. And that's really why the Big Three were brought to play, was that the three exercises have been shown to have decreased distal pressure or discal pressures in the lower lumbars compared to the muscle activity. And so there's high muscle activity with low discal pressures, so we're safer. I'll write down what those are again, but those are number one, side plank. And Dr. McGill recommends 7 seconds times 12 to 15 reps each side. Then we have number two, we have a modified curl up. And then we have number three, we have a bird dog. Okay, so that's Dr. Bowman's study. What questions come up? Anybody have any questions or comments, concerns, complaints? Take a look at that study, and then think about how does that affect your programming with your patients and your clients on how to improve their outcomes, whether it's from a non-involved side, or it's just a systemic effect, or it's trying to work muscles that are proximal to the cuffs, like a glute is a great example, a glute or a hip. All right, thank you guys so much. I'm 1:15. I try to keep these things so they're just a quick lunch and learn. Plus I've got patients in about 15 minutes and I need to eat. So thanks so much for your time. I will be back next Tuesday with another BFR message. Thanks so much.